2-minute anaesthesia in critical care. Let's review the essential topics regarding clonidine and dexmedetomidine. Clonidine and dexmedetomidine are both imidazole derivatives. Clonidine was initially investigated for the treatment of hot flushes in the 1970s, whilst dexmedetomidine was developed in the 1990s and approved for short-term sedation in the US in 1999. They both have a range of uses and involved in the management of withdrawal, hypertension, analgesia, sedation, and enhancing anesthetic techniques. They both come in oral and intravenous preparations. Classically, clonidine tablets contain two strengths, 100 mics or 25 mics. Clonidine liquid contains 50 mics in 5 mils, whilst an ampule is usually 100 mics per mil. Conversely, dexmedetomidine is usually expressed at 100 mics per mil solution for infusion. Clonidine and dexmedetomidine are both alpha-2 agonists with a high affinity 200 and 1600 for the alpha-2 versus alpha-1 receptor, respectively. The cardiovascular effects are bifold: peripherally vascular smooth muscle vasoconstriction, which leads to a transient hypertension due to vasoconstriction, whilst the central effects are central and therefore will lead to reduction of blood pressure. Sedation. This is achieved by alpha-2 receptor stimulation, leading to inhibition of adenyl cyclase, reduced levels of cyclic AMP, inhibition of calcium entry into nerve terminals, and thus hyperpolarization, and suppresses the release of noradrenaline from the locus coeruleus. Analgesia is due to the level of the dorsal horn due to reduction in levels of nociceptive signals. This may involve substance P, but also cholinergic and serotonin systems. It can be given via a range of routes: oral, intravenous, central neuraxial, and as mentioned, perineurally. Clonidine can be given at an IV or oral dose of 100 to 300 micrograms every 8 hours, or an infusion of 100 to 150 mics per hour. Conversely, dexmedetomidine usually has an initial rate of infusion of 0.7 mics per kilo per hour, and then a stepwise adjustment as per regional and national guidelines. The systemic effects for both agents include attenuated stress response to intubation whilst maintaining respiratory rate. The central cardiovascular effects lead to reduction in SVR, heart rate and blood pressure. The CNS effects include sedation, anxiolysis, analgesia, and a reduction in MAC. The endocrine effects relate to inhibition of the stress response, and they can also cause reduction in GI motility. They are both well absorbed and have protein binding of 30%, volume distribution of 2 litres per kilo, and a pK between 7 and 8. They both undergo hepatic metabolism, and finally elimination. Clonidine is 50% unchanged in the urine, whilst dexmedetomidine is only 1% unchanged in the urine. Rapid administration of both agents can cause transient hypertension, and if they're rapidly stopped, you can develop hypertension, tachycardia, headaches, and irritability.